Welcome to this webinar on understanding miscarriage. My name is Ishola Agbaje. I'm a consultant gynecologist and the medical director here at Belfast Fertility. I know there's people perhaps joining from Northern Ireland and England and so forth. We at TFP wanted to run this webinar in association with the White Butterfly Foundation, and I'm delighted to have Selina Casey, who's going to co-moderate it with me, and I'll ask her to introduce herself and the foundation in a second or two. And we really wanted to run this webinar just to really look at the profound psychological impact of pregnancy loss and miscarriage and the support that's available, and as well as, from my point of view, look at some basic clinical aspects. Unfortunately, in my day-to-day practice as a fertility specialist and a gynecologist, myself and the team take care of many women and couples who are deeply affected by miscarriage at all stages of the fertility journey and also outside fertility treatment. And as we go through the webinar, hopefully you'll see some of the more common and less common causes and potential treatment strategies and the range of support available. And also, just as a small part of this from a fertility clinic perspective, I wanted to touch on some certain circumstances that perhaps fertility treatment can help in the setting of miscarriage and recurrent miscarriage. So maybe just to start off then, Selina, I'll ask you just to tell a little bit about yourself and the foundation, the work of the foundation, and start the webinar then.
Okay, thank you, Ishola. So my name is Selina Casey. I am the founder of the White Butterfly Foundation. The foundation is a not-for-profit which was set up around this time last year to bridge the gap in psychological support services for parents that have experienced miscarriage, baby loss or neonatal death. The reasons behind setting up the White Butterfly Foundation is purely because, I suppose both from a personal point of view and a professional point of view. So whenever I went through miscarriage, it was my third pregnancy, and I was at the end of my psychotherapy training, of which I was only ever going to be working with suicidal men at that point. And then everything changed because whenever I left Causeway Hospital with my baby, I realised that there wasn't a massive amount of support out there for people who have experienced indeed miscarriage, but also people who have lost further on in their journey through stillbirth or neonatal death. The more I started speaking about my experiences, the more people started speaking back to me. And I guess every day since February 2021, I've been working on trying to make change here in Northern Ireland. And over the past year, that has been happening. We are very, very grateful to be in the position now to be able to provide support for parents who are maybe feeling that wee bit more isolated. We do that through a 3-step approach. So we work on a one-to-one basis with parents until they feel that they're in the position to maybe work in a group setting where we have our Wings peer support group. And then the third step of that is where maybe, or as part of a healing journey, you come back and volunteer for the White Butterfly Foundation or get involved in some way. That's not something that you have to do, but if you want to do, the offer is there and we will train you to make sure that you're in the right space. And I suppose for me, for the parents that I support, I completely get how important having a psychological support network is. I know that once somebody experiences loss, it doesn't necessarily mean that your journey ends there. In fact, probably 99% of the time, there's more to that journey in that either you are going to go down a route of trying to conceive, which can be extremely stressful, very, very anxiety inducing. I believe whenever month after month you're trying to conceive, it's not happening, you don't know what road to take, which is why it's so good that we're having this webinar here today, because it's good to know what is available to us, whether it's through the health service or through private facilities like the TFP. I think there's that part of a journey. There's either being pregnant after loss, which support is required for, or if you make the decision that you're not going to continue trying, that is a big decision to make, and one that I think is difficult to make as a couple alone. Therefore, sometimes a partial third party, I feel can be very beneficial. So everything that we do in the White Butterfly Foundation, all the one-to-one support is done on a free or donation basis. So I suppose that takes us on to the next slide in relation to miscarriage. So statistics are 1 in 4 pregnancies end in miscarriage, and that is what has been reported. That is what we know. We also know that a number of women miscarry at home. Sometimes those miscarriages never ever reach the stage of being reported. So that potentially could be a higher stat. So 23 million miscarriages occur globally each year, which is a huge amount. And in my work in the psychotherapy side of things, I always feel like I know a lot of grief therapists out there would be saying, oh, we don't like to work with people until 6 months after a loss. But I work from a trauma-informed point of view and always like to work with my clients as they feel ready. So the emotional impact of that is 17% of women experience moderate to severe anxiety, 6% suffer from moderate to severe depression, and then post-traumatic stress impacts 18% of women. So those stats are pretty high, and there's something that, as an organisation, we need to be doing more to help support the women partners that are going through this. So over to you, Dr. Agbaje.
Yeah, just to focus a couple of slides just on a few clinical aspects. So we use the word miscarriage actually, and I previously looked up the word miscarriage. I think language is sometimes important for people, and so I'm sure you'll agree when you're talking to people in different settings. But miscarriage is actually, it's an old English word from the 15th century, made of two things, miss and carry, and to carry wrongly is essentially the origin of the word. And actually, that's a bit misleading. I know we accept that term perhaps, and in this webinar we've used that term a lot, but by and large, for most miscarriages, actually, it isn't. That term signifies there's something wrong with the person carrying the pregnancy, whereas actually, more often than not, there is something wrong with a pregnancy that results in the miscarriage. So it's slightly misleading, perhaps has kind of negative connotations for that individual, and something that we certainly talk about clinically when we're discussing miscarriage. But pregnancy loss probably is a better description. And just for the purposes, we're going to talk about the medical terms that are accepted. Essentially, a miscarriage is defined as a pregnancy loss before the 24 weeks gestation. So really anywhere from 4 weeks, which is kind of the first time you can detect a pregnancy, right up until 24 weeks, which is the limit of viability if a baby is born. Now, most of those pregnancy losses that we would see occur within the first 12 weeks. So that's what we call the first trimester, essentially. As Selina said, 1 in 4, the statistic varies between 1 in 4 and 1 in 5. And working in a fertility clinic or an IVF unit, we'll be very used to seeing many miscarriages that occur earlier, a bit like Selina said, ones that might not be reported at home, where somebody has basically just missed a period and has a positive test. That is a pregnancy, and that's a form of pregnancy loss, sometimes referred to as a biochemical pregnancy, which just really kind of signifies that the pregnancy hasn't developed to a point where you can actually see something on scan, but nonetheless it's a loss of a pregnancy. And if people are taking a test or certainly having treatment, that's every bit as important as a miscarriage or pregnancy loss at any other stage. When you see a clinical team or an early pregnancy clinic, you might come across some of these definitions or terms that are used: threatened miscarriage, inevitable miscarriage, complete, incomplete, and missed miscarriage. These are really, they're not really diagnoses, they're sort of descriptive terms, if you like. So first of all, threatened miscarriage is essentially what would be termed if anyone is having bleeding in early pregnancy. So that essentially it's just a threat of a miscarriage. Bleeding in early pregnancy is actually very common, and it's not necessarily coming from the pregnancy itself. So people can bleed from the cervix, they can bleed after intercourse, they can bleed because of an infection, even a urinary infection or something like that. But obviously when you go and seek help, people are looking to see if they can find the source of the bleeding. So threatened miscarriage is any bleeding in early pregnancy. Inevitable miscarriage is further on from that, whereby I guess the best description is it's the process of the miscarriage happening. So where there is bleeding, we know it's coming from the uterus or coming from the pregnancy, but at that point, I guess the body has recognized that this pregnancy is not viable, not able to continue. So some other changes, anatomical changes have occurred. In other words, the cervix, the neck of the womb is opened as the body is starting to pass that pregnancy. Complete miscarriage would be a description where all of the tissue associated with that pregnancy has been passed, and that's something important when you're attending a clinic, that they check that everything is passed and no other intervention is needed. And an incomplete miscarriage is obviously the opposite of that, where some tissue remains and that would need to be managed. Another term you might come across is missed miscarriage. And actually, when I'm looking at all these definitions, sort of put myself in the place of a patient, and some of these terms sound very old fashioned, or they sound quite difficult. But a missed miscarriage is effectively just a description of a miscarriage that's occurred with no symptoms. So commonly we might see this in patients that have had treatment in the IVF clinic and everything has gone well, and they come for a scan at 7 weeks and nothing has changed. They feel pregnant, they've had no bleeding, nothing's happened. Then we get a scan, there's no heartbeat, and at a particular point in the pregnancy we would expect to see a heartbeat or a certain amount of growth. Or sometimes people get as late as a booking scan in a hospital, so around about 12 weeks, and they're devastated by the fact that this has just come out of the blue. So that describes a missed miscarriage. And the other one that you might hear talked about is something called an anembryonic pregnancy. So again, it's quite an old-fashioned term, but that is a type of miscarriage whereby at the scan we see a pregnancy sac, but we don't see the contents of that pregnancy sac that we would expect to see. So usually a fetal pole, so the very early development of the baby, and a heartbeat. And typically, as we'll see, different causes, but typically that's often associated with a genetic or chromosomal problem with that pregnancy. So those are some of the terms that you might hear. You'll see written down. In terms of symptoms, as we've said, quite often one can have no symptoms with a miscarriage, and that is particularly hard because there's no warning and you just come for a scan and suddenly delivered that news. Often people might feel that they had some pregnancy symptoms that tend to disappear or they lose that. So and people very early on are very sensitive to the pregnancy hormones, so would get, symptoms of nausea, breast tenderness, bloating, and they're used to that getting progressively more intense as the pregnancy progresses and there's sudden loss. And that's really reflecting a pregnancy that has failed and the hormone levels are going down and those symptoms are being lost. We talked about bleeding, and bleeding can be variable, and bleeding during early pregnancy does not necessarily equal miscarriage. It can be quite common, and a pregnancy can continue in the presence of bleeding, even persistent bleeding. I think as a rule of thumb, the heavier the bleeding is, the more likely there is a potential issue. And sometimes people can have some pain or cramping, usually period-like cramps. The more you have of each of these symptoms, the more things would be of concern. And if you have heavy bleeding, sometimes people will describe that they've passed some tissue alongside that. So all of these can be symptoms. I guess one thing that we haven't talked about is two particular types of other pregnancy loss, which are quite important, certainly clinically, to rule out in anyone presenting with pain and bleeding. And one would be an ectopic pregnancy. So that's a pregnancy in a tube or elsewhere, but more commonly in a tube, which is unfortunately not a viable pregnancy and can lead to other complications that need to be spotted. And then there's a peculiar type of pregnancy loss called a molar pregnancy. Not to focus on that, but again, a type of miscarriage that needs some longer term follow-up. So that's some of the terminology that you might hear when they're talking about miscarriage. In terms of causes, I think miscarriage is one of the most frustrating things in terms of diagnosis, because often we don't have a diagnosis for patients, so we don't know why a pregnancy has miscarried necessarily. We can make suppositions, and some things are more common than others, but most of the time we can't put our finger on it, and that includes a single miscarriage or people that suffer what we call recurrent miscarriages, which are 3 or more miscarriages. As a rule of thumb, miscarriages in what we call the first trimester, so the first 12 weeks, are more like this uncertain, where we don't find a cause, and they're more common. Miscarriages in the second trimester, so above 12 weeks, more commonly, so 14, 16 weeks, what we call the mid-trimester, are often associated with a secondary cause. So those require slightly different investigation, and often you may find a cause, and that's very important to have that followed up to ensure that one can try and predict that in their future pregnancy or try and help any underlying causes that we can. To focus on first trimester miscarriages, I think by far the most common cause of first trimester miscarriage is due to chromosomal problems. So chromosomes, for anyone who doesn't know what a chromosome is a way of organizing our genetic material, our genes or our DNA. I suppose, just to use an analogy, chromosomes are a bit like shelves in a library. We have 46 of them, and on those shelves are books and pages and words and letters, and that's kind of our genes and our DNA, and they're all highly organized. And just the kind of biological complexity of sperm and eggs coming together and that genetic material mixing is a really complicated phenomenon, a complicated thing to happen, and it goes wrong quite often, and that's part of normal human biology. And that subsequent pregnancy will inevitably have chromosomal abnormalities. So in other words, it might gain additional chromosomes, lose chromosomes, or have chromosomes that are slightly jumbled, and that mean that embryo is perhaps viable as an embryo, but not viable as a pregnancy, so may well implant, but go on to miscarry. And this probably explains, there's various estimates, but probably explains somewhere around 60 to 70% of all miscarriages. Obviously, that's something that you can't know for sure unless it's tested. And in general, tissue from a miscarriage is generally tested after 3 or more miscarriages. In other words, when one meets the criteria for recurrent miscarriage. As we'll see in the IVF setting, one of the reasons why many embryos that we put back don't implant, part of that is the fact that they're not normal chromosomally, and there's forms of IVF where we can test those embryos and look at them in more detail and look at the chromosomes. The chromosomal abnormalities is at the top there because probably that explains quite a few isolated or indeed recurrent miscarriages. Next we've got there is maternal health issues. So there are particular health problems that can or are associated with an increased risk of miscarriage, and more so when these conditions are perhaps uncontrolled. So, and that would make sense, for example, uncontrolled or undiagnosed diabetes, if you have thyroid disorders, and these are very easy things to test for, where a lot of the time, if you're being seen by a gynecologist or your GP or an early pregnancy clinic, these are simple tests to do that may well be done. There is a condition that many of you will be aware of called polycystic ovarian syndrome, or PCOS. That's something I would see quite frequently in the fertility clinic as a cause of infertility, because people aren't ovulating normally. It's associated with other hormonal disturbances, particularly diabetes, and women with PCOS do have an inherent increased risk of miscarriage. We're not entirely sure why. We know that most women with PCOS who have regular fertility treatment will go on and conceive and have a very successful pregnancy. So, PCOS doesn't equal miscarriage. This is just a slight increased risk. And as we'll come on to sperm quality or sperm, it takes two things to create an embryo, not just the egg and the environment in the woman, but also the sperm and the genetic integrity of that sperm. And sperm really mostly are just a kind of tail and a head that's full of DNA, and damage to this can be linked to an increased risk of miscarriage. And that's something that I'll talk about. If we just focus first of all on the female side still, I think the really important thing about miscarriage, and the thing whilst I'm talking about some of these things, just to highlight some areas, the majority of the time it's nothing that anyone is doing. So in other words, it's not their fault, or it's nothing that they can control. Yes, there's certain things that we all have to control in our lives to reduce the risk of any health-related issue. And these are all marginal gains, I would say, rather than the absolute cause of miscarriage. So for example, smoking, if you happen to smoke, we know that there is a slight increased risk of miscarriage in smokers, but that's not to say that smoking is the cause of all of the miscarriage. I think that's really important, because there's a lot of guilt associated with miscarriage and things that, what have I done wrong to cause this? And these are, like anything, just marginal gains to help improve things. Alcohol, I guess the advice is to abstain from alcohol, or certainly have a reduced intake of alcohol. And recreational drug use, which is quite a broad category, could all increase risk. Probably BMI, quite a controversial area, but we know that increased maternal BMI is associated with an increased risk of miscarriage. And partly, again, the fertility clinic setting, that's why we have sort of cutoffs or thresholds for BMI and fertility treatment, because we know that miscarriage is slightly more common in women with a higher BMI. So again, these are things that we can do just to slightly reduce the risk. I think if you read the internet, particularly, or ChatGPT or whatever everyone's on now, almost anything will be associated with anything, including miscarriage. So you can see there things like caffeine consumption, over a certain level probably, might increase your risk. And I would say, probably the advice we generally give people is just healthy lifestyle advice, and that counts for lots of conditions, not just miscarriage. There are some particular underlying conditions that might increase your risk of miscarriage, and these are the sort of conditions that are often looked for in women that have recurrent miscarriage, or we would often look for some of these things just because miscarriage and infertility can sometimes go in hand together. So the first one there is something called uterine abnormality. So that's really just fancy terminology for abnormalities in the shape or the structure of the uterus. So commonly, sometimes what we would see is uterus is usually like an upside down pear shape. It's a cavity, and sometimes that cavity can have an abnormal shape. It can be heart shaped, or it can have a dividing line down the middle of it, something called a septum, or it can have things protruding into the cavity. So things like fibroids, which are just benign swellings of the muscle of the wall of the womb. And these can all contribute to both infertility, as I say, or an increased risk of miscarriage, and might need management. But management is it's key to understand an individual's history of miscarriage. So in other words, having a septum doesn't necessarily mean that somebody needs to have that dealt with surgically. It's only in the setting of somebody having a miscarriage one might look at that recurrent miscarriage. Clotting disorders is something that people have probably heard a lot of over the last few years, and that's the sort of aspirin Hexane story where people are taking blood thinners. So clotting disorders, really, these are what we call thrombophilias, where your blood is a little bit stickier than usual and prone to clotting, and that can be an inherited condition or it can be acquired. And there's these things called antiphospholipid syndrome or thrombophilias. And these are things that we test for again in the setting of recurrent miscarriage. And probably about 30 years ago now, this was kind of at the forefront of research in recurrent miscarriage. And it was realized that in women that have these type of disorders, by giving them a simple treatment like aspirin and Clexane, one could reduce the miscarriage rate and increase the live birth rate significantly. And then infections, that would be a less common cause, certainly of a first trimester loss, but certainly there's certain infections that one would screen for, torch viruses or listeria in second trimester miscarriages. Probably linking back just at the bottom there is the impact of age, and that's something really important not to be underestimated. And again, linking back into fertility clinic, female age is a big predictor of risk of miscarriage, and it really links into the risk of chromosomal abnormalities. And this is unfortunately something that just happens in human aging and normal human biology. And it's really because on the female side that the eggs are there the moment that you're created as an embryo and the ovaries develop, and the eggs are formed and they are with you throughout your life. And like any cell, they're subject to various environmental influences and age like any other cell in your body. So they acquire these chromosomal issues. And that's why just the chance of becoming pregnant as you get older gets less. The chance of becoming pregnant with treatment gets less as you get older, and the risk of miscarriage gets higher. And sometimes those figures can be quite startling, various estimates, but at the age of 45, coming from a 1 in 4, 1 in 5 risk of miscarriage background, probably the risk of miscarriage is about 50%. So that's incredibly high, and it links back into chromosomal abnormalities. On the male side, and this is probably a real topic for research, quite topical, sperm DNA damage is something that you might read about a lot. So, as I said earlier, the sperm, largely speaking, is a vehicle just to get the male genome or the male genetics into the egg. And the cell is not made of much but DNA in the head, and that can be damaged for a number of reasons. Lifestyle conditions similar to female side, smoking, obesity, like poorly controlled diabetes. That was the subject of the research that I did many years ago. I did a PhD and I looked at diabetic men DNA damage, and in fact, going right back to I guess it was like the 1950s or 1960s, it was noted that partners of diabetic men who were poorly controlled had a slightly higher risk of miscarriage, and probably the mechanism was through DNA damage. And there are other things like infections, sexually transmitted infections that can damage DNA. And we know that the age effect with sperm is not quite the same as the female effect, and that's really largely because new sperm are being created all the time. But we know extremes of age on the male side can affect sperm DNA and other genetic aspects. So I think the difficult thing is we don't have an exact test for this. There are lots of commercial tests out there, be it for largely on the fertility side, which is of course related, but we don't really know what the right test is or what to do with the results or what the right result is. So probably outside research studies, it's not really recommended to do sperm DNA testing, but I think lifestyle modification would play an important part. So reducing weight, stopping smoking, vaping, controlling your diabetes, all these sort of things are things that potentially would help, but again, not necessarily the cause. So we've already talked about miscarriage in the first 12 weeks is more common, around 1 in 4, 1 in 5 pregnancies, but we often don't have an identifiable cause. And most miscarriages are due to chromosomal problems. Recurrent miscarriage is 3 or more miscarriages. They don't necessarily have to be consecutive. You can have, normal pregnancies in between. And probably that's a probability calculation, essentially. And the chance of that happening is probably in about 1% of women will have recurrent miscarriage. If you looked overall, it almost seems cruel when you see people with miscarriage. Now, it's not definite, in terms of when you trigger investigations, but often people might find it almost cruel that we don't do extensive investigations until someone has 3 or more miscarriages. And largely the reason for that is the investigations that we do mostly will come up normal, the vast majority, unless there's something specific, of course, in somebody's history or, there's an age or something else. But that's the reason why underlying it all, it's quite a sort of big haystack and a small needle to find that patient that is going to benefit from a particular intervention, which has its own risks. So these are things like aspirin, heparin that we've talked about. The best management of miscarriage and recurrent miscarriages through very skilled early pregnancy assessment units. So in Northern Northern Ireland here, every hospital will have an early pregnancy assessment unit, which is run usually by highly qualified and competent specialist nurses, and perhaps, a consultant linking in with them. And they sort of follow current guidance and research. And I think research is a really important thing to mention, because we don't have all the answers to all of this. And you certainly have difficult cases that we get involved in research, and probably some resources that we can share after this. But Tommy's would be a research organisation that would do a lot of research into early pregnancy loss. And I think it's certainly my practice is, rather than giving empirical treatments that, kind of sound good, or one was read on the internet, like steroids or immune therapy, this sort of thing. These things we don't have good evidence for and have significant risks, so should be done in the context of a research project or a research organisation like Tommy's. But early pregnancy assessment units are great places to guide investigations and treatment. You see all the treatments there, sort of aspirin, heparin. High dose folic acid is usually used for some of these sticky blood conditions, a particular condition. Vitamin D, these are easy things that we can do in this part of the world where we're kind of replete of vitamin D, essentially because of the climate. So sometimes people will need vitamin D supplementation, and that's something generally prenatally we would recommend. And more recently, there was some evidence that taking progesterone in form of pessaries may be a benefit in some women with recurrent miscarriage who have early pregnancy bleeding. So this is something that we're seeing more and more people request. Probably the last bullet point is really just to highlight the fact that in our IVF practice and fertility practice, there is a niche area for some couples or some women who may use IVF as a tool to help reduce the risk of miscarriage. So again, it's back to chromosomal problems, and some people have or carry a particular chromosomal problem. So during their investigations for recurrent miscarriage are identified as carrying a chromosomal problem that doesn't affect them but might increase the risk of miscarriage in any pregnancy. And that group of women can benefit from potentially having IVF, creating embryos, and actually testing those embryos to see if they carry the normal complement of chromosomes or not. So that's a technique called PGT, which just stands for pre-implantation genetic testing. And that particular technique is PGT-SR. That's looking for structural rearrangements in their chromosomes. And we also find that patients do pre-implantation genetic testing for the other one, aneuploidy, which is applied just to a general population of patients having treatment where we're looking at the embryos. And in IVF, Selina and I were talking earlier on, coping with fertility treatment and the uncertainty of fertility treatment. Having a miscarriage associated with that is hugely devastating to anybody. A miscarriage is devastating. Having fertility treatment can be devastating. You're combining both together. So sometimes we would use that technique of pre-implantation genetic testing for particular patients who, for example, have had a number of miscarriages in the past, not necessarily recurrent miscarriage, but feel that they want to reduce their risk of having a miscarriage in treatment, or they've had recurrent miscarriage, or they tend to be sort of older patients where they're more likely just statistically to have a miscarriage and they want to avoid it. So not to focus on that, but that is the one area that IVF can help in terms of miscarriage. Having IVF per se, just regular IVF, does not really reduce the risk of miscarriage unless you're applying a technique like genetic testing, which we sometimes do. But I think, again, it's about talking to your specialist nurses in your early pregnancy clinics, gynecologists, and they may point you in the direction if that's something that is likely to help your own circumstances. I guess this is the final kind of clinical slide, is just about what is done once a miscarriage is diagnosed. Well, I guess the first thing to say is that the diagnosis is often not just on one occasion. Sometimes it is possible to diagnose what's happening on one occasion, but more often than not, you might be asked to have, a further scan. And that again can be very distressing, particularly when you've been told that in all likelihood this pregnancy is not continuing. But I think it's important that there's not diagnostic uncertainty, and that's a big reason before acting upon it, that the team looking after you are absolutely sure that there's no growth of this pregnancy is not continuing. And sometimes there can be uncertainty. I've already mentioned that the early pregnancy assessment units are really the place to have care, and care is really coordinated there. They're coordinating the clinical aspect and some of the support that they can signpost you to that Selina will expand upon. And again, arranging investigations if they're appropriate in terms of recurrent miscarriage, and often they're a point of contact for future pregnancies, whereby they can offer you an early scan for reassurance. And often, in many cases, or majority of cases, that's what's required, rather than any clinical intervention. Most people will end up with a good outcome in the future with good support, and that's probably one of the most important things: emotional support and that clinical support and providing reassurance. Probably won't go in any huge detail in terms of management options when miscarriage is diagnosed. Suffice to say that really there are three. When I started as a gynecologist, probably surgical management of miscarriage was really at the fore, and we probably managed most miscarriages surgically by undertaking a procedure to sort of deal with the miscarriage, the uterus itself, and remove the tissue and make sure everything was safe. That's quite invasive for a number of reasons, and I think over the years there's been a real move towards more conservative management of miscarriage, maybe taking a wait and see approach or using medication to try and deal with the pregnancy for you. Those methods, it's very much an individual choice and an individual basis, and what's going on, but sometimes the conservative medical management can be more prolonged. That aspect of the care can be more prolonged than the surgical management, but any team in an early pregnancy clinic will discuss all the pros and cons with you, and make sure that whatever choice that you make is the right one for you. Okay, so I think, Selina, I'll hand on to you then just to...
Yeah, so you touched nicely there, Dr. Agbaje, on the importance of the emotional and the psychological support following a miscarriage, and especially, I think in any area where somebody has lost a pregnancy. But as we talked about earlier on, there is that added layer of complexity when somebody has went through a full process of a fertility journey. I think that's where it's really important for the likes of the White Butterfly Foundation to scoop in and offer that support as soon as you feel that you are ready to receive some sort of psychological help. And that doesn't need to be a real intense week-on-week basis. That can be some way and suits you and what works for you. I think that's how we work a bit differently than other counselling practices that aren't maybe baby loss related or baby loss specific. What we do is we very much work, rather than saying I'll see you every week, we work with what works for our clients. So something that has come up time and time again is that it doesn't matter, no two miscarriages are the same, and that goes for two miscarriages with the one person. Miscarriages, as I said here, a deeply personal, often misunderstood experience. I think we live in a society, or there's this perception where, well, that's really sad, but she'll be grand, or they'll be grand, they'll get on with it. But sometimes it's much deeper than that. So there are some people who are grand and get on with things quite quickly. There are others that are completely floored by the whole experience of a miscarriage. And especially, I think, whenever you've been through the whole process to get to where you are in a fertility journey, to go through IVF, and then for this to happen, there is such a profound sadness with any kind of miscarriage, but especially whenever somebody has went through the journey of IVF, which is particularly difficult on a woman anyway. So whether it happens early or later on in pregnancy, the emotional and psychological impact can be profound. So I experienced 3 miscarriages, 3 experiences that were all completely different and all at very different stages. And I would say every single one of them had their own trauma and a completely different trauma, which is why as a trauma-informed therapist and somebody who uses somatic techniques to work with trauma, I think it's really important that we work with you as early on in your journey as we possibly can. So everyone processes their loss differently. And I think that's something that I always hear, and Dr. Agbaje had touched on it earlier on, where there is a lot of self-blame often happens whenever somebody loses a pregnancy. I have heard things from, I took 2 paracetamol that morning to I had a coffee till I was drinking before, I had a few glasses of wine before I even knew I was pregnant. I had my seatbelt on too tight. I've heard so many things, but the underlying thing is that there's always so much shame and blame comes with miscarriage, and the majority of the time it is absolutely nothing that you did wrong. As Dr. Agbaje said, it's quite often a chromosomal indifference that causes for it to happen, and nothing that you could have had control over. I think it's important to honour your unique response without comparison or judgment. So I have worked with many clients who have experienced miscarriage, some who are actually quite shocked that they're okay. and others who are quite shocked that they're not okay. And in fact, today I spoke with a lady who, her first miscarriage, she was absolutely, she just could not get out of her bed, that feeling of wanting to put a blanket over your head the whole time. And then she had another miscarriage. Her whole family expected her to fall apart, but because she was in therapy, she actually managed it not too bad. She actually felt okay, and she was questioning herself why she was feeling okay. But I think it's important that we honour the situation that we're in and go very, very easy on ourselves, and don't expect that you're going to deal with something the same as what your friend has, or somebody that you're maybe in a group with has, or indeed maybe a previous loss. You don't judge yourselves on other people and on different situations. So some common emotional reactions to miscarriage: whenever you lose a pregnancy, you are grieving. I don't think there would be anybody on this call who would disagree with me in that the minute you see the two blue lines, you have that feeling of, oh my word. Well, I know for me, certainly in my first two pregnancies, it was complete excitement. Third pregnancy, complete excitement, but then once I experienced loss, I was almost frightened to be excited. But there was that underlying, oh my word, my life could look very differently in 9 months. And I think that's always what's there. This could look differently in 9 months, or what is this going to look like? And if it's your first time being pregnant, a lot of the time we're thinking of prams down the line, we're thinking of nurseries. The minute that is taken away from us, we are grieving. We are grieving for all those milestones that we should have met. We are grieving all those, like, first days at school, the anniversaries, the due dates. There's so many dates associated with a miscarriage that it's very, very, very difficult to go through that part of your journey without actually honouring, well, it's okay for me to feel this way. I think whenever we're in our own heads and we're feeling like we have lost control, or that one day equals a bad year, or I'm never going to be okay again, it's important to note that one day is a bad day, and the next day we're going to get up and we're going to try again. And if that day's bad, we need to continue to try and bring ourselves to a point where we're actually, do you know what, it's okay to feel sad, because I am sad. It doesn't mean that I've completely lost. Again, guilt and self-blame, as I mentioned earlier, it's almost never your fault. Anxiety about future pregnancies, pregnancy after loss, is one of the most anxiety-inducing times. I know myself, after being pregnant after loss, like, I was making excuses to go to the toilet. I myself, my first miscarriage was a miscarriage. I was still making excuses to go to the toilet to see if there was any blood. And I know that pregnancy after loss is an extremely difficult time, and it's a time when you do need that psychological support. And again, numbness or shock. Sometimes people have a delayed response to this. Sometimes they completely, what we would call in the counselling world, is dissociate. So we put it into it, we get on with our own life and just get on with things, which I think is the way we deal with things a lot here in Northern Ireland. And I always say trauma is one of those things that can stay in the box until it doesn't. So my personal thoughts around dissociating is, if you feel that you're doing that, get yourself into therapy and start to work through it, because it will come out at some point. And if you're in a position where you're trying to conceive, which probably a lot of people are that's on here today, that's not where we want you to be. We don't want you to be logging it. We want to process the emotions associated with this. So again, just being mindful that partners may cope differently, which can create challenges. And I find a lot in the work that I do is that whenever a couple have went through a miscarriage, is that both can grieve in very different ways. And it's what we call in the counselling word dual process. So one person's approach to grief would be just get up and get on with it and try to be the supportive one, whereas perhaps the other person feels that they're stuck and just can't get on with life. So it's very, very important as a couple that you're mindful of each other and how your grief may be very different. So there's no small loss. Every miscarriage is significant. It's something that I come across in this community. I feel is like, depending on when you lost, yes, there is differences at every stage of pregnancy loss, but it's important to know that I feel that in most situations, it's just a different type of trauma that we're dealing with, or a different type of grief that we're dealing with. So it's important that you know that if you have been through an early loss, if you've had a chemical pregnancy that has completely left you in a pretty bad way, it's important to know that that was significant for you. And again, what I would say is reach out for help. All emotions are valid. So from overwhelming grief to relief. So sometimes what I find is, especially for people who are pregnant after loss, they find that they never get to that stage where the two, and people probably on this call will understand, whenever the two blue lines are there, a lot of the time people get excited. But if you have lost previously, often that excitement is ripped away from you and it's just dread. And sometimes the woman I work with would say, I just knew that this wasn't going to be the outcome I wanted, and therefore whenever they do miscarry, sometimes they do feel relief and they feel absolutely shame to feel that way. So again, all those emotions are valid. It's all part of a grief cycle. So you're allowed to feel what you feel. Your grief is your own and it matters. And I would suggest that if anybody's sitting here thinking, some of that resonates with me, I'm not quite sure where I'm at in my journey, don't know how I'm feeling, but I know I'm really wanting to try to conceive, we need to get you in the best possible mental state for you to continue with your trying to conceive journey. It's so important that if you have unprocessed trauma, that we work with that. So that takes us in, I suppose, so the next big part there about seeking health is strength. There's nothing easy about walking in the doors of a therapy room or picking up a phone to ring somebody like, say, for example, the White Butterfly Foundation. What I would say is you can self-refer into the White Butterfly Foundation through your website. There's a contact page on there. If you're sitting there and you're thinking, God, I would like a wee bit of help, fill it in. If it gets to the point where we chat and you think it's not for you, that's fine too. There's no harm done. As I say, it's a free service. It's something that we want to be able to provide to the people of Northern Ireland. And again, if there's people from England here, we're not going to turn anybody away. We're currently working with people in England and Scotland as well. So if you do need that support, please fill in the form on our website and we will get in touch with you. I think sometimes that makes it easier if we break that. You don't have to lift the phone if we do that for you. So I think there's a note there as well about counselling services aren't just for when grief becomes overwhelming. What I would say is let's get you in here and get you the help before it does become overwhelming. Support for partners. So supporting one another can be a crucial part of the healing process. What I find when I work with couples is that once we start opening up and we find out what's going on in each other's heads, and often whenever we're in a partnership, we think we know what's going on. Do we ask the questions enough? Probably not. What I think it's really important that we are very open and transparent as part of our grief journey. So the impact on our partners may feel helpless or left out of the grieving process, especially if you are the person that has been through the miscarriage, the physical side of it. A partner can very often feel like, well, I feel really useless here. I don't know what to say. I don't know what to do. Don't know where her head's at. I just want to make everything okay for them, but I have no idea how to do it. And that's where we need to come out and start talking openly about how we're feeling. So acknowledging their grief and being open with each other. So the communication is crucial, and it really is whenever it comes to keeping relationships on track. And especially if you're somebody who's had a miscarriage, going through an IVF journey, you're trying really hard to conceive, we need you both to be on the same page and we need you both to be in the same mindset. So support for family. So grandparents, siblings and other relatives may grieve too. So it's really important that we don't leave them out of the equation. Helping older children to understand in an age appropriate way. Whenever we'd lost our wee boy, my kids were 6 and 8. That was something I found difficult, was breaking that news to them. I think we done it in an okay way. We kept them informed the whole way through, and they talk about their wee brother. And for us, that was the way that worked. That won't be the way, like we talked earlier, nobody's two situations are the same. Maybe for another family, 6 and 8 is just too young to break that message. I knew for my kids they would be able to handle it, and they have. But for another family, that might not work. But that's something that we do. The discussions need to be had about how do we support the other people in our lives. What I say sometimes is, often whenever we're going through this journey, we can be difficult to support because sometimes we don't know ourselves what we want. It's very easy to turn against those that are trying to support us. It's something that I've learned in my own journey, is that being very transparent with other people as well and letting them know, well, actually, you said something there that was highly insensitive and please don't say it again. And the majority of the time, our friends and family don't want to hurt us, but they just don't know what is the right and wrong thing to say. And I think it's up to us to say, well, actually, that's a bit offensive at this point in my journey. So effective communications is listening without judgment, and I suppose that goes both ourselves and those trying to support us. Avoid cliches, at least you can try again. That is the worst thing you can say. If I could write, I think, a book on what not to say would be very helpful to the families that I work with. Seek couples counselling if needed. I think there's a bit of a stigma around couples counselling. If you're going to couples counselling, you must be on the verge of breaking up. That's not the case. In fact, I find most couples that come for couples counselling are actually the ones are trying really hard to make it work, want to make it work, and are just there for some clarity. So I think we need to break that stigma around what counselling is, around why people go to. I think it's something that Americans do quite well. Generally, therapy is just part of their life. And I think we could probably do with going down that route a wee bit more. So just moving on then on future pregnancies, I think it is very important to be supported. I think that miscarriage is a devastating time, and I think parents need supported through that. But then, as I mentioned earlier, there's always a subsequent part to that journey. So whether that's trying to conceive, pregnancy after loss, or deciding not to try anymore, those are very big decisions that are the next part of the crossroads, I guess. So addressing concerns, so feeling hopeful yet anxious is very, very normal. Very normal. It's something that I lived with for a long time during my trying to conceive journey. So most people who experience miscarriage go on to have healthy pregnancies. I am testament to that. I have worked this year in itself with a number of women who have had some of the saddest situations, who have now went on to have healthy pregnancies. So just because it has happened, it doesn't mean that you're never, ever going to be able to conceive. And I think one of the big things here is holding on to that bit of hope, which is really, really hard. It's really difficult. And I know it's really difficult if you've been going through maybe continuous cycles of IVF and it hasn't happened. Holding on to that hope is so important. It's difficult, and that's why you get a therapist to try and help you through that. So when to seek medical advice? So after 2 or more consecutive pregnancies, if you're over 35 or have existing medical conditions, or if there are complications or difficulty conceiving again. So prenatal care and early monitoring. I work very closely with the Causeway Hospital, their early pregnancy unit, and it's something that we have discussed on a number of occasions. A lot of the time, it's not about doing like loads of different tests. A lot of the time, it's having that relationship and having a good support network in place. So scheduling regular scans for reassurance. And a lot of the time, what happens is consistency is so important that you don't have to regurgitate your story to every single person that you meet in the medical setting. So maintaining a healthy, balanced diet. We all know it. We all know what we should eat, but it is so important in this journey. And invest time in emotional well-being strategies. And I mean, I'm a therapist. I think it's something that's so important, is to invest in your emotional health, especially in this journey, because I know myself that this can become a rabbit hole that you go down and can consume you if you don't have somebody there that's impartial. And I always say, I don't say that people are on their own because they have a partner generally or they have a good family, but what they're sometimes lacking is the impartial person who is in the therapy setting, who can give you an impartial point of view without you thinking that somebody's maybe attacking you or not agreeing with you. It's just an impartial point of view. Guys, thank you so much for logging on. Any questions, please fire them through to either uk.inquiries@tfpfertility.com or to me at Selina@thewhitebutterflyfoundation.co.uk, and we will get back to you. Thank you, guys.
Thanks a lot.